Saturday morning was, can somebody please come over and check my wife? I'm not sure she's breathing. I went running over there, and what I discovered was a young woman sitting up barely on the side of the couch. She had pancreatic cancer. It had spread to her liver. Her belly was distended. She was having a hard time staying awake, and he was very lovingly but forcefully trying to say, you need to eat, you need to drink something. Their understanding was that there was still some hope for treatment, and that they were told to just keep feeding her so that she had the strength, and that 2 days later they were going to go to another cancer center up in Phoenix. What I had to tell him very quickly is that that was not going to happen. In fact, his wife was dying at that point, and also, in fact, that pushing the food and fluid at this point was going to increase her discomfort. This gentleman was devastated. He said, why didn't anybody tell me? This is the love of my life. We have never had an argument in our marriage until several weeks ago when she just said she couldn't eat anymore. And I kept saying she had to eat, she had to eat. If I had only known what was happening, if I had only known that it was creating more discomfort, I never would have done that. So it was devastating to him. We certainly got hospice involved and got the hospital bed, and the final 26 hours of her life, he lay next to her, held her caringly in bed. They were surrounded by people who loved her. We kept her comfortable. But the tragedy is one that I hear way too often, which are these words, which are, if I had only known. And so I think our call is to say we have to provide information compassionately, more timely, and the patients and families have to be willing to ask the difficult questions so that whatever decisions you make, it's really based on some good information. So here's the issue I deal with a lot in end-of-life issues. There's death, trying to hail a taxi, and he says, cripes, there goes another one. What, am I invisible? You know, for a lot of folks, dealing with facing mortality is just not something they want to do. So even if somebody is diagnosed with an end-stage illness, they figure, well, if I put the blinders on, if I don't make eye contact with death, it isn't going to happen. If I don't finish my paperwork, it isn't going to happen because God's certainly not going to take me off the earth if my paperwork isn't done. And one of the reasons we do that is basically we're scared because we're so separate from dying now. It doesn't happen in the home. 80% happen in an institution. So, I took a Gary Larson cartoon. It gives you the jitters, the heebie-jeebies, the creeps, etc. We hear some of the difficult stories, but we also don't get to witness the deaths that can be absolutely as beautiful as birth, in fact. So part of the issue in preparing for this is the ability to communicate. And they did a survey of families whose loved ones had died, and they said, what are the biggest areas that we need to improve to make it better for future families? Far and above, communication, as you can see on the scale, was number one. Even beyond physician skill and palliation, they said we really need to improve care of communication. For those of you who are in this field, this is probably no surprise to you. Anyone who's also dealing with communication issues, you also know that communication with the dead is only a little more difficult than communication with some of the living. How do you talk about the difficult topics if the physician's not comfortable with it, if your spouse is not comfortable with it, if your children say, no, Mom, you're going to live forever? So communicating is difficult, but the consequences of not communicating can be absolutely devastating, and everybody really pays a price for that. So let me give you some examples of a price a patient may have paid. I was admitting a gentleman to hospice, and he had esophageal cancer. He'd had it for a couple of years, and it had already spread to his lungs. He'd already had all the chemotherapy and radiation he could have for his lung and lower esophagus. But now the tumor was back, and it was growing in the lower esophagus and into the stomach and causing bleeding, requiring blood transfusions about every 7 to 10 days. So they couldn't offer any more treatment for that part of his cancer. However, it had also spread to his brain. And they said, oh, but we can treat that. What the patient did not know are what it meant to treat or to not treat the different options. What would it be like to have whole brain radiation? What would it be like for his daily schedule? What would it be like to have that cancer treated but to have the other cancer grow unchecked? What would it be like to die of esophageal cancer or growing more into the lungs? And what would it be like to die of anemia if you chose to stop the blood transfusions? So I kind of laid out all the options for him because this is a gentleman who wanted to know. And he was so grateful. He said, this is a no-brainer. I'm stopping the blood transfusions. So he had a very comfortable death. About 5 days later, he could stay at home. He was surrounded with the family. But had we not had that talk, probably his last days would have been spent going back and forth to the hospital with some side effects. Family plays a price, too. There was a woman I worked with. Her husband had lung cancer for 8 years in and out of treatment. It had now recurred again. And the physician said, well, here's another drug we can try. Well, when they looked it up, that particular drug for his particular kind of cancer had a 0.2% chance of response. Not remission, not cure, response, which is medically can be anything over 2 weeks. It carried a price tag of $52,000. Now, in front of the physician, the family said, okay, let's go for it. But I spoke to the wife later on, and she said, what am I going to do? I'm 72 years old. We're barely making it financially. This is going to wipe us out. He's going to die anyway, but what kind of wife would I be to say no? And then I spoke to the patient separately, and he said, I am so sick of treatment. I don't want any more. I don't need any more, but my poor wife. She'd feel I was abandoning her if I did not accept it. So we really had to get everybody's truth onto the table to say, what are we doing here? What are the consequences, and what are the goals? What we know is that insurance, that bankruptcy, the number one cause of bankruptcy are health care bills, and that's with people with insurance. Now, I want to be very clear. I am not putting a price tag on the cost of living. What I am doing is putting a value on it. At what point do we say that's enough? And those are personal questions for people to ask. What am I willing to pay for 2 more weeks of life, for 2 more years of life? Because that might look a little bit different. But we have to be able to communicate about it for us to make decisions based on our own values. So let's talk about some of the barriers. Unfortunately, I've got a long list here. Sometimes it's just because we don't have a crystal ball. We may not know how somebody's going to respond to treatment. But if it's a recurrent disease, we may have a little bit better picture. Now, can we ever say what your prognosis is for certainty? No, we really can't. And people fool us wrong, show us wrong all the time. I mean, prognosis, physicians, the studies have shown that they're wrong about 72% of the time. Oncologists tend to overestimate length of life. But what you can do is say, tell me the range. Is it months to a year? Is it months to 5 years? And then prepare for the shortest and rejoice in the longest if you've got that. That way you're not living with that regret of, okay, they said up to 5 years, so by gosh, I'm going to have 5 years. Another barrier is simply the fear, and fear of talking about it, because sometimes families feel that if they ask a physician, is this going to be the end of me? Is this treatment really going to work, or is it really just, placebo effect, that the physician may feel that they're not trusting them, or they may sense that if I talk about it, it's going to jinx me. We had a young woman who was admitted to the hospital, and the oncologist called me and said, I want you to talk to her and admit her to hospice tomorrow. And I said, well, wouldn't you like me to go see her today? And he goes, no, I'm giving her chemotherapy today. Well, what happened is he said, I didn't want her to give up hope. But what this young woman did then with that, she was 32 years old, she felt that as long as she was being treated, that there must be hope, and therefore to talk about end-of-life planning for her son or to get closure with her mother would have been jinxing her. So nobody talked about anything. That night she went into a coma, and she died 2 days later. More barriers. I said I had the long list. Sometimes just lack of information. Finding out what is the benefit and burden of any treatment. I think it's difficult because when you're in a sense of overwhelm, it's like, just treat me, let's take care of it. But really ask us to paint the best picture we can about what the benefit or burden of any treatment is. And what I've done is on one of my websites that you'll have a link to later, I have a list of questions that you can talk to your physician about, and a list of questions that you can talk to about with your family to really explore how you're making your decisions. Also to understand, how is this disease going to progress? How am I going to manage that? Maybe there's some alternative ways of managing it too, but just get a complete picture on which to base whatever decisions you choose to make. Also, be very clear about what your goal is. Is the goal cure? Is the goal remission? Is the goal comfort? There may be many more aggressive treatments and side effects that you're willing to tolerate if it's a possibility of a cure. It may be a very different set of treatments you're willing to accept if we're looking at comfort. And we really want to find out, is that treatment supporting or detracting from that particular goal? But always base any decision on your goal. Other barriers: fear of failure or death. Now, the good news is things are changing out there in the medical and nursing schools, but the reality is a lot of us were not prepared to talk about death and dying when we were in our training. And physicians, as the studies have shown, in an old study, said that they had the highest fear of death, and of the specialists, it was the oncologists. Now, this does not make them bad people at all. This makes them very caring people, because you come to the office and they're thinking, I'm going to raise that sword and I'm going to fight this cancer for you. So putting down the sword and raising the white flag is very difficult, and it feels like failure. Attachment. We grow very attached to the people we work with. We become part of your family. So, yeah, it becomes really difficult to have to say, wow, we've kind of crested that hill, and, we got to prepare for something different. And then it's also the language we use. We are so comfortable with our medical jargon that sometimes we don't know that you don't understand it. And to be a good patient, sometimes patients and families nod their head like they get it, and they have no clue what they're saying, and we don't take the time to say, tell me what you heard me say. Now, this ad comes from a medical journal, which I love, and it says, medical studies indicate most people suffer 68% hearing loss when naked. What we know about adult learners is that optimally, if you are rested, you don't have any physical issues, you're not distracted, etc., you will remember 70% of anything we have to say. You add a little bit of distress physically or emotionally, it drops down to 40%. So you can imagine that if you're suddenly faced with some really bad news, the ability to hear may go out the window. There's a fabulous nurse I know, been a nurse for 45 years. Her husband is a physician, very knowledgeable, and she said, when the oncologist told me that I had stage 4 breast cancer, after that moment I heard nothing. I know she went on to tell me, how she could treat this and how well I could do, but not only could I not hear it, I didn't have the ability to say, stop. I need time to absorb this. Come back later. So sometimes we think people are in denial because they didn't hear things, but we're just being human, that sometimes we simply cannot absorb it. And our job as professionals is to come back and say, do you need some space? Tell me what you heard me say so we can continue to reinforce important information.